Dear friends, colleagues, ladies and gentlemen, my talk will be about cardiac implantable device detected atrial tachyarrhythmias. How about thromboembolic protection threshold? As we know well, atrial fibrillation is a major health care problem associated with increased morbidity and also mortality. And stroke is the most common and dangerous complications of this disease, which may occur in patients with AF, either as the initial presenting manifestation of the arrhythmia or despite appropriate antithrombotic prophylaxis. In such patients, a cardiac embolus, most commonly originating from the left atrial appendage, is a common cause of ischemic stroke. And of course, stroke is another important and common healthcare problem. In many patients presenting with stroke, we may find the underlying etiology. About 15% of stroke are attributable to documented atrial fibrillation, and 50 to 60 to documented cerebrovascular disease. And 1/4 of strokes are of unknown cause, and subclinical atrial fibrillation may be a common etiological factor in this group. And cardiac implantable devices, including pacemaker, CIED, CRTs, and ICDs, they are very commonly used, and there are almost 7 million cardiac implantable device patients worldwide, and more than 1 million more are implanted each year. In addition to their well-known and proven benefits, some devices can detect atrial high-grade episodes, which are known as ARIA, and also subclinical atrial fibrillation, which usually occurs in individuals without characteristic symptoms of atrial fibrillation and without a prior diagnosis. And subclinical atrial fibrillation includes ARIA episode confirmed to be atrial fibrillation, or atrial flutter, or an atrial tachycardia, or atrial fibrillation episode detected by insertable cardiac monitor or wearable monitor and confirmed by visually reviewed intracardiac electrocardiograms or ECG recorded rhythm. And most of these individuals will have paroxysmal atrial fibrillation. And because of the clinical importance of ARIAs, the previous EF guidelines recommended to integrate pacemaker and ICD on regular basis for atrial high-grade episodes. And the authors of the guidelines also noted that patients with ARIA should undergo further ECG monitoring to document atrial fibrillation before initiating atrial fibrillation therapy. And the most important issue about the patient with ARIA and subclinical atrial fibrillation is stroke risk prediction, and of course to decide how to prevent stroke. In a co-regression analysis performed on more than 8,000 patients without oral anticoagulation as baseline, device-detected atrial fibrillation burden was associated with an increased risk of ischemic stroke. And increasing EF burden was significantly associated with age, CHAS score, and history of previous stroke. These results were also confirmed by another meta-analysis, which showed that subclinical atrial fibrillation is strongly associated with clinical atrial fibrillation and stroke risk. However, although subclinical atrial fibrillation is a risk factor for stroke, please note that risk seems to lower than that of clinical atrial fibrillation. This might be related to problems in diagnosis of the arrhythmia and low arrhythmia burdens observed. At that point, I can say that it is very clear device-detected arrhythmias increase the risk of stroke. However, there is uncertainty regarding the minimum duration of device-detected atrial fibrillation that increases thromboembolic risk. And it is not clearly defined so far which patients with ARIA or subclinical atrial fibrillation have greater risk for thromboembolic events. One study showed that atrial tachycardia or atrial fibrillation burden 5.5 hours or longer on any 30 prior days appear to double thromboembolic risk. However, another study, the MOS trial, found that patients with sinus node dysfunction who experienced ARIA lasting at least 5 minutes were more likely to have adverse clinical outcomes, including a higher incidence of stroke, death, and subsequent atrial fibrillation than patients without ARIA. And 4 years ago, the ESC atrial fibrillation guidelines stated that ARIAs increased stroke risk, but it was unclear whether they benefit from oral anticoagulation or not. Oral anticoagulation was recommended only if there is ECG documentation. Because of the uncertainties I have discussed, it was not clear in this document how to manage the patient with ARIA, but without ECG documented atrial fibrillation. And a few years ago, ERA published a consensus document shared by me to discuss these uncertainties and provide statements and recommendations to practitioners. We presented some facts and also consensus statements and recommendations in this document. We used colored heart figures in order to make statements and recommendations easily understandable. Green heart means recommended or indicated. Yellow heart means may be used or recommended. And finally, the red heart means shouldn't be used or recommended. And we strongly recommended that, if available, review stored intercardiac electrocardiograms to confirm diagnosis and exclude artifact or reduce the effect of oversensing and also undersensing by automated algorithms. And we also noted that the presence or absence of symptoms has no bearing on determining the need for anticoagulation. We listed the causes of inappropriate EF detection and solution by device programming. False negative detection includes true atrial undersensing, functional atrial undersensing, and causes of positive detection include ventricular far-field oversensing in atrium, myopotential oversensing, electromagnetic interference, lead failure, and finally ineffective atrial pacing. For stroke risk assessment, we recommended to use CHATS score as used in patients with ECG documented atrial fibrillation. And for bleeding risk assessment, we recommend to use Hayes score, and noted that a high Hayes score is not a reason to withhold anticoagulation. And here are the recommendations for anticoagulation. The presence of RA longer than 5 minutes is associated with an increased risk of stroke and systemic embolism, especially in the presence of 2 or more risk factors using CHATS score. Thus, oral anticoagulation should be considered in such patient, whether as a NOAC or well-controlled vitamin key antagonist with TTR over 70%. And as you can see here, we use yellow heart for this statement. Actually, we reserved green heart for longer duration of AHR episodes. Oral anticoagulation is strongly recommended in our paper for patients with 2 or more CHATS score and lasting longer than 5.5 hours in 24 hours. And finally, a few months ago, the new ESC atrial fibrillation guidelines discussed this important issue with the details. And the writers of the guidelines recommended that in patients with ARA or subclinical atrial fibrillation detected by the devices or implantable devices or insertable cardiac monitor, it is recommended to conduct complete cardiovascular evaluation with ECG recording, clinical risk factors, comorbidity evaluation, and thromboembolic risk assessment using CHATS score, and continued patient follow-up monitoring, preferably with support of remote monitoring to detect progression to clinical AF, monitor to RA subclinical AF burden, especially translation to 24 hours or more, and detect changes in underlying clinical conditions. However, please note, as we mentioned in the ARA device-detected subclinical atrial tachycardia document, there is no established cut point for increase in risk and no minimum duration that is without risk. There doesn't seem to be a close temporal relationship of device-detected atrial arrhythmias to the occurrence of stroke. This implies that in the majority of device patients with RS and thromboembolic events, the mechanism of stroke may not be related to EF episodes. Most importantly, the benefit of oral anticoagulation based solely on device-detected subclinical atrial tachyarrhythmias for reducing the stroke has not been examined. I think two ongoing trials, NOAA, EFNet-6 and Artesia, will provide much needed information on the effectiveness and safety of oral anticoagulation using non-vitamin K antagonist oral anticoagulants in patients with atrial high-grade episodes. For the conclusion, ladies and gentlemen, 25% of strokes are of unknown cause, and subclinical EF may be a common etiologic factor. Cardiac implantable devices with an atrial lead allow continuous monitoring of atrial rhythm, and using this technology, patients with subclinical atrial fibrillation and a-fib can be identified. They are associated with an increased risk of overt atrial fibrillation and also stroke. It is recommended to assess eligibility for oral anticoagulation using CHA2DS score and use oral anticoagulant for device-detected error episodes. Although there is uncertainty regarding the minimum duration of device-detected atrial fibrillation that increases thromboembolic risk, the risk is higher with higher arrhythmia burden. Controlled trials evaluating oral anticoagulation in ARIA patients are ongoing and will provide evidence on the best antithrombotic therapy in this patient. Thank you for your attention.
Thank you for nice presentations. I have one question. Can we call subclinical atrial fibrillation as silent atrial fibrillation?
Absolutely no. It is completely different. Subclinical atrial fibrillation is defined as episodes of atrial fibrillation detected by intracardiac implantable wearable monitors and confirmed by intracardiac electrocardiograms or review of the recorded rhythm on the ECG. It is usually occurs in individuals without characteristic symptoms of EF and without a prior diagnosis. But a patient can also be symptomatic rarely. Silent EF is symptomatic EF diagnosed with ECG. It is an important, or it is a symptomatic form of atrial fibrillation incidentally diagnosed during a routine test or manifesting as an arrhythmia-related complication. It's clear?
Thank you. Thank you.
Thank you, doctor, for your nice presentation. I have one question. Do you recommend oral anticoagulation for a lady with CHA2DS score 1 who had long AHRE episodes?
Actually, no. Her thromboembolic risk is low. Neither guidelines nor our consensus report recommend anticoagulation for such a patient.
Thank you very much.
You're welcome.